All right, Pharm week 3, volume and ions. All right, so maintenance of fluid and osmolality generally is due to the job of the kidneys. That's the primary thing that's maintaining that. We can have volume contraction and volume expansion. Contraction is going to be where we have a decrease in total body water. It's like, it's getting smaller, it's contracting. So it's getting smaller. And this can either be hypertonic, isotonic, or hypotonic. Volume can also expand so that we have a volume fluid or fluid volume excess, which is going to be where we have an increase in total body water. And this can be isotonic or hypertonic, and I imagine also hypotonic. We also have tonicity, which can play a role into that as well. So isotonic is where it is normal. So here we've got our red blood cells. They have their own solutes inside, all those electrolytes and anything else that might be in there. And they're locked in there. And then we also have the fluid that's attracted to the inside, the red blood cells, because of those solutes. And then we have an equal amount in proportion of solutes and solvent on the outside, and everything remains happy and equal, and that's isotonic. With hypertonic, there is suddenly a change in the fluid outside so that there is more solute concentration compared to what's inside the red blood cells. And so that fluid is going to want to try to equalize that solute concentration, and the only way it can do so is by leaving the red blood cells and going out to the interstitial space. And then we have hypotonic, where the solute solution outside the red blood cells is less concentrated. So there are fewer solutes in proportion outside compared to inside the cells. So a lot of this fluid here is going to see, hey, we've got a whole bunch of extra solute in here that's not attracting as much. We're going to go ahead and go in here, and we're going to then lead to these red blood cells rupturing after swelling. So we can have hypertonic, isotonic, and hypotonic, I think, contraction, and then same thing for expansion. With isotonic contraction, sodium and water are both lost in proportion to each other, so there's no change in osmolality. And we can get this through things like vomiting, diarrhea, kidney disease, diuretic misuse. The vomiting and diarrhea, from my understanding, it seems to be that each individual situation can kind of be different. And so with certain cases, the vomiting diarrhea may have a much higher load of certain electrolytes, making things more hypotonic. Maybe there's less solutes or fewer solutes, and so we have a more hypertonic result. It doesn't always seem to be, if you have vomiting, if you have diarrhea, then it's definitely going to result in isotonic contraction. We kind of look to identify, do they have contraction or volume contraction? Okay. What state is it currently in? Okay, that's probably because they've been vomiting for the past 3 days. So treatment is going to be fluids that are isotonic, because we just need to replace in proportion the fluid because there's no change in osmolality, so we're going to use something like normal saline. And we're going to replenish slowly so that we don't get a bunch of extra fluid overload and pressure that results in something like pulmonary edema. With hypertonic contraction, we've got more loss of water compared to a loss of saline, or sodium. So we have kept most, if not all, of the sodium, and we've lost primarily water. And so what we are having is a decrease in the volume ECF, which is just the blood, the plasma, and we now have a more syrupy, higher concentration of solute, so kind of a syrupy blood, not super syrupy, otherwise we would die. So this can come from excessive sweating, osmotic diuresis, so that mannitol, enteral feeds, I don't understand why that is, burns, CNS disorders, interfering with thirst. I don't know, I would need to see more of these in person. We're going to give them hypotonic fluids to offset the fact that they are hypertonic in their current state. Or we can give them D5W, which is a wonderful infusing solution, and it has no solutes at all, though it does have, it's dextrose 5%, so it has sugar and stuff in it. But we can also just simply have them drink water, because that's going to go in, and as long as it's not like a super minerally water, then it should be good to start them on replenishing that lost fluid. Hypotonic contraction, this is going to be where we are losing primarily sodium, less water, and so we're left with this really diluted, the opposite of syrupy, plasma state, so it's even more liquidy-ish than it would be otherwise, or when it's normal. So perhaps we've got excessive renal sodium loss, so we've got ourselves an overdose of aldosterone. Lack of aldosterone, too much diuretics, too many, chronic renal insufficiency. They're doing a poor job of reabsorbing that sodium the way it's supposed to be, and so we're left with this dumping of sodium out through our kidneys into our urine, and we've got this hypotonic contraction. So treatment, if it's mild, we're just going to give them some normal saline and call it good. That'll kind of offset what was there. If it's severe, we may want to give them a full-blown hypertonic solution. I'm not even sure what that would be called. Of 3% normal saline, I guess, or sodium chloride. And watch for, making sure that we're not giving them too much fluid to lead to pulmonary edema or pedal edema. Those are where we're going to be kind of watching, monitoring to make sure that we're not giving them too much or too quickly. Volume expansion is also possible. It's a little less common unless we're talking about things like CHF. CHF is going to be the primary cause of pathologic volume expansion, as well as nephrotic syndrome or anything with the kidneys where the kidneys are collapsing and they're not able to really filter out that fluid. Treatment's pretty easy. We give them diuretics or use agents for heart failure. Typically, they respond very quickly and very well. If they have if they have kidney failure or something like that, then that's also the hepatic cirrhosis with ascites. That's where you're going to have that massive pot belly filled with fluid. It's very firm. You see these massive, what's the word for peritoneal arteries or veins running up and down the belly. It is a very striking image, and what they do with that is they stick needles, literally just these giant friggin' needles into their belly and suck out all this fluid, and sometimes you can take out liters and liters and liters of fluid, and then suddenly now they're just a normal looking alcoholic. Not trying to be discriminatory, that's just kind of what they look like. Potassium, this is going to be our most abundant intracellular cation or cation, though I've also seen that with magnesium. Extracellular concentrations are low to maintain that excitability of the cells. We're good for nerve impulses, electrical excitability of muscles. I had something on there. Where was... Okay, so I had to look through a little bit. So there is some impact of potassium and acid-base balance. I'm trying to remember exactly what it was. So potassium and hydrogen ions are both able to go into and leave the cell. And typically they do so in an inverse relationship or with an inverse relationship. So as potassium leaves the cell, hydrogen ion will then go into the cell and vice versa. So if there is some reason for why, if there's suddenly like an influx of potassium, um, a lot of it may go into the cell, causing, like extra may go into the cell, causing whatever hydrogen ions are in the cell to come out of it, leading to metabolic acidosis. I don't know if that's exactly what may happen, but if, say, we have too little potassium in the extracellular fluid, so in the blood, then the body's going to naturally adapt by sending potassium from inside the cell to the plasma instead, because they want to maintain the plasma more than the cells themselves. And what that's going to do is that's going to shuttle hydrogen ions in to replace that potassium, because of their equal charges, into the cells, leaving fewer hydrogen ions outside the cell, making it more alkalotic. It could actually lead to metabolic alkalosis. Okay, so potassium levels generally are controlled by the kidneys, and renal excretion exists by way of aldosterone and most diuretics, with the exception of those potassium-sparing diuretics that are later on in this slide. And its influence, potassium levels are influenced by the extracellular pH, where alkalosis will shuttle cells into, or potassium into the cells, and acidosis will shuttle potassium out of the cells. And then insulin also will shuttle potassium into the cells, which is why insulin can be a great choice to help make potassium levels normal during acidosis. So with hypokalemia, we're going to give them some potassium salts. Those potassium salts are going to have chloride in them for the most part, because generally when we have hypokalemia, we're going to also have that chloride deficiency, hypochloridemia. I'm not sure if that's the right word. And so we're going to treat both together at the same time. We're going to give them food and water because we know that there is a substantial amount of abdominal discomfort that can occur with giving potassium via oral route. Nausea, vomit, diarrhea are very common. We can also give them the sustained release version, like the enteric-coated pills, to help reduce the severity of those symptoms. We can also give them, if it's a severe form of hypokalemia, IV potassium chloride, which we need to make sure is absolutely diluted, because it can be very, very, I want to say, corrosive to the veins. And then we want to infuse it slowly, because we can develop hyperkalemia and send our patient into cardiac arrest, and that's not normally good. A vesicant which is what IV potassium can cause, is an agent that causes blistering of the skin and to the vein. We never do an IV push, and just so everyone knows, IV is different than IV push. IV push is going to be using a syringe to inject into a line a medication, and you're squeezing it with your thumb. IV implies that there is a infusion over time. So that's the difference there. And if we've got like hyperkalemia, then we're going to treat by holding any extra potassium. Don't give them any nanners. We don't want to give them any drugs that promote potassium accumulation, so we're going to hold off on our spironolactone or triamterene, which are our potassium-sparing diuretics. There's a definite risk for cardiotoxicity, because with hyperkalemia, we need that sodium and potassium to work appropriately with the cardiac musculature to cause proper conduction. And so if it's hyper, then that could lead to cardiac arrest and death. So we're going to give them potentially some calcium gluconate, depending on how severe the hyperkalemia is, just to help dull the excitability of the cardiac tissue. We also want to maintain, or to help take care of the extracellular potassium while the body kind of takes care of itself by infusing insulin and glucose, because we're given some insulin, to shuttle that potassium into the cells. If they are acidic, which can happen just from them being hyperkalemic, well, actually, I'm trying to think now. If they're acidic, then we can also give them some sodium bicarb to help take care of that sodium, the acidosis. And then also, K-Electrolyte is another one we can use to help take care of some of that potassium. I haven't heard of that one before, but I saw that online a couple times when reading about this. And then if it's really severe and they're not responding well, then dialysis is an option. If we've got hypocalcemia, just give them some potassium or calcium salts and some vitamin D to help with absorption. If they are hypercalcemic, then we want to decrease their calcium and vitamin D intake, replenish their fluids with isotonic fluids because of two reasons. One, hypercalcemia can often damage the kidneys, making it more likely that they can experience some sort of acute kidney injury. But they also are going to be trying to filter out so much of this extra calcium, and that extra calcium can develop calcium stones inside the kidneys. So we really want to make sure that we're diluting this calcium enough to allow it to safely get out without clogging anything up or causing damage. We want to give them some loop diuretics because loop diuretics actually promotes calcium loss in the distal convoluted tubule, and then mobilize the patient, since mobilized or immobilization is a risk factor for hypercalcemia. And so while mobilization is also great for trying to prevent it, it can also help once they've developed it to just get things moving and allow for that calcium to enter the bloodstream and get the heck out of there. If it's really severe, again, we can do dialysis if we need to. Magnesium, required for a lot of enzymes, RNA, ribosomes, all that. The big one for us is that it is important for neurochemical transmission and excitability of muscles. I'll take it. If we've got hypomagnesemia, then we're going to increase their intake either via food or supplements. Maybe we can give them IV or IM magnesium just to make sure that they've got it. If they're really, really low, more often you'll see that in with pregnant women and in cardiac arrest if they have a specific rhythm called torsades de pointes, which is sort of similar to VFib. Yeah, that's a little more information than anyone needs. Hypermagnesemia, we treat that with some IV calcium gluconate because that helps to antagonize the cardiovascular excitability that can occur from hypermagnesemia, similar to, which one was it? Our hyperkalemia, calcium gluconate. We also give some normal saline and furosemide to try to get the body to naturally just kind of expel a lot of that magnesium out. We may want to give dialysis or use dialysis if they have renal insufficiency, or if it's to the point where it's 8 milliequivalents per liter. I believe normal is 1.5 to 2.5, and so 8 is extreme. Or if they start showing some severe cardiac or neuromuscular symptoms, because anytime we've got a electrolyte imbalance, especially something like magnesium or potassium, we're looking at a very significant chance for dysrhythmias and death. Case studies, diuretics. Okay, I'm not going to really touch on renal review much. Okay, all right, so diuretics, in general, their purpose is to block the reabsorption of sodium and chloride in different parts of the nephron. Generally, the more proximal The diuretic acts on the nephron, the more profound reaction or an effect it makes. Because the more proximal the nephron is, or that section of the nephron, the more that part of the nephron naturally will reabsorb sodium and chloride. So, the sooner we act on the nephron, the more profound an impact we can make. So obviously, if we do diuretics too well, then we lose a whole bunch of fluid, leading to hypovolemia. With diuretic use, there's also the potential of influencing acid-base imbalances, specifically metabolic alkalosis, as I was mentioning earlier. So we've got the intracellular levels of potassium and hydrogen ions, and they've got that inverse relationship. So as one enters the cell, it's going to shuttle the other one out in the same proportion, basically. So if a patient becomes hypokalemic from using diuretics, like thiazides or loop diuretics, then the intracellular potassium will leave the cell to try to regulate and make sure that the plasma levels of potassium are within range, or are as close to being in range as possible. But in order to do so, it's got to send, or hydrogen ion naturally will want to go back into the cell, leaving a more alkalotic state outside the cell. So that's where we would end up getting a metabolic alkalosis from taking diuretics. And of course, we can do or get electrolyte imbalances because if you lose too much sodium or if you lose too much potassium, you suddenly have a electrolyte imbalance. You can also lose too much chloride, but that's not as common. So we've got our loop diuretics, of which furosemide is going to be our main doohickey. We've got thiazides like hydrochlorothiazide, osmotic diuretics, mannitol, and then our two potassium-sparing diuretics, which are going to be spironolactone, which is an aldosterone antagonist, and triamterene, which is a non-aldosterone antagonist. And then, I don't even know if we touch on this, I don't think we do, carbonic anhydrase inhibitors. I don't know what those are. I'm just going to put that out there. Lasix, this is going to be pretty much our go-to powerful diuretic. So this is going to block sodium and chloride from reabsorbing naturally at the ascending loop of Henle. So we go down the loop and then we go back up the loop. So it's going to happen as we go back up the loop. It's going to be a very rapid onset. We can give it PO, which is great. And that will be used more often for patients who have mild to somewhat moderate pulmonary edema with CHF. And then we also have the IV version, which is going to be starting to act like right at 5 minutes. And that's going to be when someone's got these really strong crackles in their lungs, they're having severe dyspnea, they're starting to go kind of cyanotic. It's like this person may go into respiratory failure if we don't do something now. So we're going to inject them with some Lasix. And that's going to cause them to start peeing like a racehorse. So of course we're going to be using this for pulmonary edema, any other kind of extreme edematous state, hypertension. So of course we've got a bunch of electrolyte issues with using loop diuretics. We can get hyponatremia because we're releasing a lot of sodium, hypochloremia because we're releasing some chloride, dehydration, losing a whole bunch of fluid, which if we're losing a whole bunch of fluid, that means we could lose too much and we become hypotensive. So, and we also could have the potential of ototoxicity, which is basically just deafness in the ear. No, deafness in the eye, Josh. Deafness. So this is generally transient. I don't understand why it happens. I didn't really care to look too much into it. The book doesn't say much. Just know that if a patient starts to complain about Like I can't hear out of my left ear, or I feel like I'm really now having a hard time hearing anything, or I can't hear at all. Um, More than likely, it should be transient. Um, we don't want to use this in pregnancy because during animal trials, it resulted in death. So we have some more adverse effects. So hypokalemia, and some people are actually kind of confused on how hypokalemia results from Lasix or thiazide use. So the basic way it works is that loop diuretics and thiazides are going to dump a heck of a lot of sodium into the tubule, and as it does so, it's going to start pulling a whole bunch of water. Excuse me, a whole bunch of water, and there are going to be cells in the collecting duct that are going to detect this sudden influx of sodium, and their natural response is to basically doing a chain of events that eventually signals aldosterone to be released, and aldosterone is going to turn on sodium potassium pumps in the collecting duct because they're trying to reabsorb a bunch of that sodium because they're like, whoa, hold up, we're not supposed to lose this much sodium. That's not what we're here for. So they're trying to reabsorb sodium. They're not going to do a very good job compared to Lasix and thiazides because Lasix and thiazides have multiple times the dumping of sodium into the tubule compared to what those sodium potassium pumps can return to the body. But what the sodium potassium pumps are going to be really good at is getting rid of potassium because, like any sodium potassium pump, you have to exchange 3 sodiums for 2 potassiums molecules. So as they're trying to get that sodium back into the body, they have to do so at the expense of excreting potassium into the tubule to be urinated out. So that's how we end up getting this this loss of a bunch of potassium. So we also have sometimes hyperglycemia. I have no idea why. The book didn't really go into detail on that. And then hyperuricemia is common. It comes from the retention of uric acid. It's not really asymptomatic most of the time. And so what we're going to do is we're just going to simply tell the patient, hey, this could be something you might experience. It might get some gout-like symptoms. So be aware of any kind of tenderness or swelling in the joints. If you notice it, call us. And then we also can have an increase of excretion of calcium and magnesium. So educate patients. This may be one of those times where you just give them a piece of paper and say, if you start feeling any of these, just let us know. And then also Lasix tends to have a negative impact on lipids through raising the LDL and lowering HDL, which is the opposite of what we want. And so this may have this is a bad thing, but it doesn't actually seem to have any impact to coronary mortality at all. Okay, so and back on that calcium magnesium part, we're going to watch for things like muscle weakness, tremors, twitching, dysrhythmias with that hypomagnesemia, because remember, with calcium and magnesium, hypo states means that there is a hyperexcitability. So we want to be looking for things that things that indicate a hyperexcitable state. Yeah. The hypocalcemia is actually, though, able to be used, the effects of Lasix creating hypocalcemia, as we mentioned earlier, is something that we can actually use to our advantage when we have a patient who is hypercalcemic. All right, so we do not want to be giving this with digoxin, or we at least want to be very, very, very careful giving it with digoxin. Digoxin is one of those medications we take for or give for heart failure. But digoxin, the primary reason why someone goes into digoxin toxicity, which digoxin has a very narrow therapeutic index, The main reason why it goes into toxicity is because of hypokalemia. And with loop diuretics, there is a good chance that a patient may experience hypokalemia from those sodium potassium pumps trying to bring in sodium at the expense of potassium. So really the best thing to do here is to either find a different medication to take instead of digoxin, or we can just put them onto a potassium-sparing medication for another diuretic on top of Lasix. Autotoxic drugs are ones that we may want to avoid taking with Lasix, since Lasix does have a autotoxic concern, and taking them together can just profound and potentiate that effect. Potassium-sparing diuretics, this would be a benefit since we will have a minimal amount of extra fluid loss from taking that potassium-sparing diuretic, but we will maintain appropriate levels of potassium that way. We want to be very careful taking lithium with Lasix, since lithium is very sodium dependent for excretion. And so if we have a state where we have a very low level of sodium because Lasix works by dumping sodium to get rid of water, we may end up having lithium toxicity because lithium requires salt in the blood to be expelled from the body. And then antihypertensive agents, ACE inhibitors, ARBs, they work together well to help maintain antihypertensive actions with Lasix, so we're good there. Be careful taking NSAIDs with loop diuretics, because NSAIDs are going to cause, as with virtually all COX inhibitors, are going to cause renal artery constriction, leading to a lack of renal perfusion. And so if we do that, it's basically going to limit how much of an action loop diuretics can have on fluid loss. Okay, so thiazide diuretics. So hydrochlorothiazide is going to be working on a very similar way as Lasix, just in a different area. So instead of the ascending loop of Henle, which is where Lasix works, this is going to work on the distal convoluted tubule. So this starts a lot longer. It works a lot slower than Lasix does. Lasix at PO is about 60 minutes, whereas this is about 4 to 6 hours. And I don't believe hydrochlorothiazide is able to be given IV, whereas Lasix is. So Lasix would be our emergency drug of choice for getting rid of fluid. This is going to be more of our more common, mild to moderate fluid overloaded patient from CHF, whereas Lasix is more, I got a lot to get rid of. So it's significantly lower than that. It's not so great though when a person has, say, some kidney problems and they don't have much urine to give out. So if we're looking at a GFR of less than 20 to 30 mils per minute, then we may just have to work with Lasix. So we're going to be using this for something like essential hypertension, which is primary hypertension, meaning that we have no real secondary cause. This is what the vast majority of people have, whereas like secondary hypertension is something that comes from something else, like a kidney problem that's limiting how much fluid we can get rid of, causing hypertension. We use it for edema, like in CHF, or diabetes insipidus, and we don't know why, so there's no point in figuring that out for us as nurses. We have a bunch of adverse effects that are very similar to, if not identical, to Lasix. So we've got our hyponatremia, low salt, low chloride, not enough fluids, low potassium, same thing for the other one. Again, hyperglycemia, hyperuricemia, same impact on lipids, calcium, magnesium. Same concern with using it with pregnancy and lactation. So this is basically a picture-perfect identical copy of what the issues were with Lasix. Same thing over here as well. So there's no point in beating a dead horse. So when we are giving a patient Lasix or a thiazide, we want to really make sure that we're closely monitoring the elderly because they are at a much higher risk of developing side effects and losing too much fluid compared to our normal, younger, healthy, I don't want to say normal, compared to our younger populations. So we're going to be checking things like their weight on a very regular basis, especially if they had a more urgent form of fluid overload. We're going to be assessing for thirst, urine output, color, quality, quantity, their clotting status. Why does it say headache under clotting status? I don't know. We're going to be checking their potassium and all of their electrolytes, really, just to make sure that we're not losing too much of anything that we don't want to lose. In diabetic patients, because of the risk of hyperglycemia, we're going to want to check their blood glucose on a more regular basis, or really making sure that we are watching out for hyperglycemia. If a patient has had previous gout, then we're going to want to check that uric acid. And then teach them all the different things that could go wrong with taking Lasix so that they can be on the lookout for it when they're taking it at home or in the hospital. So now moving on to our potassium-sparing diuretics. These are going to have a decent amount of urine production, but the main reason for why we take them is to combine them with our loop and thiazide diuretics to help offset the loss of potassium. So we've got our aldosterone antagonist, which is spironolactone, and our non-aldosterone antagonist, which is triamterene. As was mentioned, they are rarely used alone. So spironolactone, this is going to block aldosterone, specifically block aldosterone in the distal nephron. Remember that aldosterone is what comes in to try to activate those sodium-potassium pumps in the distal end of the distal convoluted tubule in the collecting duct to try to reabsorb all that sodium that's being lost by taking a loop diuretic. But as it's doing so, it's taking in sodium at the expense of potassium, so we're losing a whole bunch of potassium. If we block aldosterone, none of that takes off. None of that gets going, and we can keep our potassium, and we're happy. And we have an increased amount of sodium excretion, but it's minimal, and we can just simply adjust our loop or thiazide diuretic to make sure that the total amount of sodium that's lost is what we're hoping for between the two medications. So the onset can take a very long time, and yeah. So we're going to use this for things like hypertension, demodistates, heart failure, because there are some protective effects of aldosterone blockade for the heart and the vessels. I don't know exactly what they are, but they seem to have found some beneficial things from it. And I guess it's only good for severe heart failure. We can use this for primary hyperaldosteronism since we're talking about blocking aldosterone, and the primary function of aldosterone is on the kidneys. So if we got too much aldosterone, block a good bit of it and we're happy. And then it's also possible or possibly good for polycystic ovarian syndrome and acne because spironolactone is a steroid derivative, and so it has some of those steroidal benefits. We can also get hyperkalemia because any medication that works well can work too well. So if we try to save potassium, we can save too much. Dizziness, dry mouth, nausea, vomiting. I don't know why that is. We can have some endocrine effects because, again, spironolactone is a derivative of a steroid. So we can get things like gynecomastia. That's an important one to talk to your patients about because if you are giving it to a guy and suddenly he develops breasts, he may be really, really concerned and upset about that until you let him know, hey, that's normal with this medication. We can try to change it to something else if that helps you. Or yeah, otherwise they're just going to be in full-on panic mode. I can tell you that for sure. We also have the potential development of benign and malignant tumors that they've seen in animals. We don't know whether or not that's actually the case in humans. And then along the same side with the steroid derivatives and endocrine effects, we can cause some menstrual irregularities and impotence. Another important one to tell your guys about. And for women, this is important as well. So, drug interactions, we have some helpful effects from thiazide and loop diuretics. And then we also want to be careful with giving it with any other agents that can raise potassium. For example, ACE inhibitors, ARBs, renin inhibitors. All of those can all of those can increase potassium levels in the blood. So we want to be really careful about giving them alongside our spironolactone, since we may just get a super high amount of potassium. Triamterene, this is going to work by disrupting those sodium-potassium exchanges, the pumps themselves, in the distal nephron. So we're going to decrease, it's not going to work. We're not going to have that same sodium reuptake or reabsorption. We're not going to have the sodium or the potassium excretion. It's going to block the effects of aldosterone. Spironolactone blocks aldosterone, whereas triamterene blocks those sodium-potassium pumps. This is going to act faster than spironolactone and is again good for hypertension, edema, mostly just trying to fix potassium. And as with the other one, with spironolactone, hyperkalemia is our main concern with taking triamterene. It won't be as common if we're taking it along with a loop diuretic or a thiazide. We can also experience leg cramps, nausea, vomiting, not diarrhea, dizziness, and some blood dyscrasias are possible, but rare, which is just going to be some sort of a blood cell or platelet malfunction, like having hypercoagulability. Don't know why that is, but that's something that can happen. So when we are talking to our patients about potassium-sparing diuretics as a whole, we want to talk about hydration and the importance of hydration, and monitoring it. So we want to tell them, check your weight every morning before breakfast. Choose either before going to the bathroom or after going to the bathroom. Monitor your thirst and let us know how that's going. Look for urine output. I'm trying to remember what the book said about clotting status. Because I know that potassium is important for clotting, but I don't remember. I should probably have looked it up before making this video. Electrolytes, potassium spared. So we want to check for hyperkalemia. Identify those who are taking anything else that might increase potassium even more, and teach our patients to report certain symptoms. Osmotic diuretics. So mannitol is freely filtered in the glomerulus, and it just yanks in water from wherever it floats to. So this is great in particular for things like ICP, or increased ICP, intracranial pressure. It goes up to the blood vessels in the brain, creates this incredible osmotic pull of fluids from the interstitial space, and then allows for it all to go draining out through the urine. And acts very quickly, 30 to 60 minutes. It's only ever given IV because it can't cross that GI epithelium. There's very minimal reabsorption and metabolism, and it's inert. So it's really overall a safe medication, but it's really only good for a few things, to try to prevent renal failure, for example. So if they have severe dehydration, hypotension, hypovolemic shock, we may give this to help maintain renal perfusion, because renal perfusion, once you stop shuttling or putting water through the kidneys start to shut down and deteriorate. So we got to keep perfusion through the kidneys. We would, of course, give fluid on top of that via IV in massive boluses, but the kidneys may take a while before they start to get natural perfusion back, because the main thing is that the body wants to protect the heart, the liver, the brain. So we got to help maintain the kidneys on our own. It's good for intracranial pressure, and then it's also good for intraocular pressure. I don't know anything beyond that. The adverse effects, so I don't exactly understand how this works, but we can get some edema. We can leak, I guess, some mannitol out through certain capillaries. So if we've got a heart failure patient, then we want to be really careful about this, because if the mannitol does leave the capillaries at the level of the feet or the lungs, then we can cause a very severe set of symptoms for them. And this is why generally you're not going to see mannitol used for heart failure patients, and instead we use Lasix, because it may just make their symptoms that much worse. And then, of course, we may get a headache because we're losing a bunch of fluid volume in the head. And unlike what people think, a headache actually tends to come not from having too much fluid, but comes from too little fluid. Don't know why we might get nausea and vomiting. And then, of course, fluid and electrolyte imbalances, because we are messing around substantially with fluid. So we're going to check for our high-risk patients, those who have already established edema from CHF, and those who may already have some sort of electrolyte imbalance to begin with. And then we're going to want to check our electrolyte levels. So as a more kind of visual of what's going on here, I don't know what this is. I'm thinking that must be our carbonic anhydrase inhibitor. Never learned about that. Mannitol is going to work up here. That's why it produces such a massive level of diureses. And then all the way down here, and mannitol works down here too. Our loop diuretics are going to work on the ascending loop of Henle. Thiazides work up here at the distal convoluted tubule. This would normally be very squiggly. And then our potassium-sparing diuretics are going to work around the distal DCT and the collecting duct. I think that's it.